Can I now invite the panelists to comment on the session and this lectures, please? Dr. Uday Khanolkar first, followed by the other panelists. Dr. Uday Khanolkar, please.
Yeah, my question would be to the first speaker about echocardiography for the diastolic dysfunction, mitral left ventricular diastolic dysfunction. Now, in practice, we use these parameters of diastolic dysfunction for basic diagnosis of diastolic dysfunction, and over a period of time, how it is responding, if at all, to the treatment and the management. But this dynamic assessment of diastolic dysfunction, how can it be extrapolated in the ICU or during the surgical procedures which are done?
Dr. Jeevananandam, are you there?
Good morning, sir. Am I audible, sir?
Yes, please.
Sir, good morning, sir. The guidelines actually specifically say that these guidelines cannot be used in the perioperative period. This is assessment of by all the echocardiograph parameters cannot be used in the perioperative period. They suggest not to use. But we have no other goal but to use these parameters to know what exactly the problem with the LV is. So even though they keep changing, because by the time of induction to this open, there should not be the amount of fluctuations in the hemodynamics and the maneuvers we do to reduce the pressure, like giving bolus of NTG, all those things tend to decrease the severity of MR, the LV filling pressures or the diastole. It is just like this, can compare it to this ischemic MR, where so we can assess what the problem with the ischemic MR, but we cannot simulate the pre-operating conditions in the intraoperative period. Only thing we can know is we can know how bad the LV is, how bad the diastolic dysfunction is, and we can know how much amount of filling the LV can take. So basing on this, we can judiciously give volume to the patient. Say for a patient with type 1 diastolic dysfunction, your primary aim is to fill the patient as much as possible. Because this patient, even though the LV has a diastolic dysfunction, the LA is compensating by this atrial cage. So if you give a volume, the LV is going to respond to your volume. On the contrary, in a type 3 diastolic dysfunction patient, although the LA filling pressure is high, if you start loading the patient with too much of volume, the LV is going to definitely fail because it is not going to take any more volume you are going to push in it. So by knowing what category the LV falls into, we can judiciously administer fluids for these patients, particularly in the cardiac surgery and the post-cardiac operative period, where fluid balance is most important on all these dysfunctional patients. And this is dynamic. As you say, it is very dynamic. It keeps changing. But I tend to take whenever there's a type 2 dysfunction, I start to fix on that. And we try to reduce it because we have drugs which specifically address the diastolic part of the LV, like the Simendan and the Miltino, which are lucitrophic drugs. And we try to salvage a bit of diastolic dysfunction. But we always treat for the worst case.
Yes, but in I have one practical use for this diastolic dysfunction, especially when I'm doing a case of ASD device closure in the cath lab. And in this situation, I keep a watch on with the catheter in the LV and also on echocardiography. When you're closing the ASD with the device, especially in the elderly, and if the diastolic E and A waves are getting worsened, that is the time we have to perforate the device. So that is one good guideline which I have learned in my practice.
Thank you, Dr. Khanolkar. Thank you for that insight into interventional uses or in interventional cardiology. Dr. Kumar, please.
Yes, sir. A very good afternoon and good evening to everyone. And thanks to the Muralidhar sir for consistent, excellent arrangements. Thank you, sir. And all the speakers done a great job. All the 4 speakers did a great job. And regarding the first talk about the filling pressures assessment, we have qualitative assessments and quantitative assessments. In that, does the E by E prime and E by A correlates with optimal filling pressure in patients with the decompensated systolic heart failure? In those patients, because the LV is enormous and indices are very poor, and also in patients with CRT, that is cardiac resynchronization therapy. My question is, in those type of patients, what is the ideal building pressure parameter? To Dr. Jeevanathan, please.
Yes, sir. Good morning, sir.
Yeah, good morning.
I'm not sure about the CRT part, but as far as the guidelines says, if there is no severe MR or severe regurgitation on that part, these are the parameters they suggest to find out the LA filling pressures. And,
If I
Okay.
may interrupt here.
Yes, Dr. Kanolkar, please.
Yes. Now, this diastolic dysfunction is very important as far as the CRT is also concerned. And because during follow-up, we cannot do invasive monitoring, which is not practical. And this diastolic dysfunction plays an important part in adjusting the parameters of the pacemaker along with the LV dimensions to optimize the effect of CRT. And it has got a very important role.
Okay,
Yes, sir.
that's,
Thank you. Regarding the second speaker, I do agree that Rajesh Arya has clearly mentioned that T is essential and very useful for cannulations as well as for MICS procedures. And about the third talk regarding the TR interventions, my question to Dr. Sureshar, again an excellent talk, sir. What are the predictors of TR recurrence in patients undergoing TV repair?
Thank you, Kumara. The two predictors that they have mentioned is one is the tenting area. A tenting area of more than 1.6 centimeters squared or a tenting height of more than 1 centimeter are highly predictive that once you do the repair, there can be residual TR present in these patients. So these are the two parameters.
Okay, sir. Thank you, sir. And one more thing regarding the tricuspid interventions, percutaneous interventions.
Yeah.
Is there any guidelines to say which group of patients should undergo tricuspid interventions or anything like that? Because we are in the initial phase of tricuspid intervention.
Yes, as of now, I'm not. I mean, cardiologists are also there in our group. They can highlight us. But as far as I know, the interventions are done only in those patients who have more than severe. As I said, one of the indications for classifying severe into severe, massive, and torrential is because of interventional procedures. What they actually happened has been that when you have a torrential TR and they do intervention, the improvement that is seen after the intervention is very difficult to assess because what they expect is a less than 2 grade reduction in the severity of the TR. For example, the regurgitant volume for mass torrential TR is around 80. So if it comes down to 40, it means that the intervention has been successful. The other indications like ability to do the procedure and patient being alive at the end of the procedure. But one of the major indicators of success is a two grade reduction in the severity of TR. But Dr. Kanolkar is there, he can highlight or tell us more about this.
Yes. The experience about tricuspid intervention has been very limited. All over the world, including us, it is difficult to do a tricuspid valve clip, like a mitra clip, a tricuspid valve clip, because the separation between the anterior leaflet and the posterior leaflet is very large and cannot be grasped in one clip. And even if we grasp it in the clip, there is a septal leaflet which is hanging, the third leaflet. So you cannot grasp all the three leaflets. So there are very anecdotal cases in as far as clip is concerned, and we cannot draw any conclusion from that. We have got one experience of a case of tricuspid valve regurgitation, inoperable RV dysfunction. In order to protect the liver, we have performed IVC and SVC valve implantation. Of course, that does not change the long-term mortality of the patient, but it only stabilizes the hepatic function of the patient. And otherwise, and again, these are all sporadic cases. There is one case awaiting where we are supposed to deploy a tricuspid valve in a patient, a valve valve in a patient who has had a failure of tricuspid valve repair in the past. Of course, that patient is being prepared. Again, anecdotal case, we may be able to do it in the next 3 weeks' time. But we cannot draw any conclusion from the literature as far as the indication, contraindication, and subsequent what is going to be the effect as far as tricuspid valves are concerned, because the volume is very low.
Thank you, sir.
Thank you, sir.
Dr. Murli would like to add and comment, please. Dr. Murli, Kanchi Murli.
Yeah. I really enjoyed the whole session. The filling pressures, vascular cannulation, tricuspid regurgitation, and artificial intelligence. Very well done, all of you. All the speakers have done very well. I'm really quite happy. I have no question, but I would like to comment that we have used the handheld device and also the standalone machine. I'm not naming the company. To look at COVID patients with these machines had artificial intelligence capable, which would tell us the VTI, the ejection fraction, IVC collapsibility, blue lines, etc. And these parameters, when compared to the expert performing and giving us the reading, it is exactly similar. So I think, as Dr. Manish has pointed out, the persons who use artificial intelligence will be, he said that the artificial intelligence will not replace the human beings, but the human beings who use artificial intelligence are much advanced and they can proceed much faster with quicker and more accurate results in their day-to-day practice. This is my comment, and I don't have any questions. I was happy with all the lectures given. Thank you so much.
That's great, Dr. Murli, because artificial intelligence is taking over the entire world, I think. And obviously, one of the things pointed out by Dr. Manish was the volumes. You could probably do more cases and, look at more patients in a same span of time as a conventional echocardiographer would do. You capture an image and do the rest. The same is happening with a lot of imagiology, MR, CT scans and things like that. COVID has changed the balance or tilted the balance in favor of artificial intelligence. Dr. Jayabal and Dr. Salome, any comments and questions, please? If you have any, then there are a couple of questions on the chat box which we could take.
All the speakers for the wonderful presentation, and I think we can go ahead and address the questions in the chat box.
Yes, please. So Dr. Sanjeevni Namdar has a couple of questions. So in one of them, she has asked whether with coexisting diastolic dysfunction and MR, how do you assess both by pulmonary vein flow patterns? This is to Dr. Jeevanandan.
Hello.
Yes, please.
Sir, in presence of mitral regurgitation, assessment of diastolic dysfunction is a bit tricky. First, we have to look at the etiology of the MR, if it is a primary MR or a secondary MR. So if it is a secondary MR, it is due to a pathology in the LV, and there is most likely to be there is going to be diastolic dysfunction. So we are not much worried about the diastolic dysfunction in a patient with LV dysfunction, because the factors we measure include compensate both for the LV dysfunction and for the MR. But we are very specific to look at whether it is due to the MR or to the LV dysfunction. We have other variables. We cannot do the conventional variables like the E by A or E by E prime. We have variables like the isovolumic relaxation time and the the ratio of isovolumic relaxation time and the time to E prime. Those things can be used. If you want to look at the specifically the pulmonary veins, in case of severe MR, there will be systolic reversal. And if you want to differentiate that from the diastolic dysfunction, you can look at the aortic reversal duration to AV velocity duration. If it is more than 30 seconds, it is more likely the patient having severe diastolic dysfunction or increased LV pressure in addition to the MR.
Thank you, Dr. Jeevanandan. That I think answers pretty well what Dr. Sanjeevni wanted. This is a small question from Dr. Joshi to Dr. Suresh. I think he did address this. He says, for a perfect TB repair and severe RV systolic dysfunction, should we avoid a perfect TR repair or go easy on the repair? Or see, because I think part of it was the interventional part, which you already mentioned. If you have a torrential, if you come down to LO or regurgitant volumes of from 80 to 40, that itself is considered success.
Yes.
So,
especially in patients who have got RV dysfunction, it is better to go slow on the severity of the repair. Because if you keep a competent valve in the tricuspid position, then RV may fail in the post-op. So a repair would always be, or a leak rather would answer the question. Definitely a leak should be there so that the RV can let out when it is understood.
yeah. Oh, and then one last question, if time, I think that's the last thing I will have since we are running short of time. This is from Dr. Satyajit Mishra, I think, to Dr. Rajesh Arya. In ECMO, what should be the position of the return cannula?
Yeah, thanks, Satyajit. I think if you're putting a return cannula in the RA, the return cannula should be just above the tricuspid wall so that it can drain both the SVC and IVC properly. And if you're using just a femoral, then it should be in the IVC or in the superior vena cava. If you're going through the IJV, it should be in the right atrium. That's what is usually done in my place.
Okay.
Yeah.
Okay.
So may I give one comment about one paper which we have published? I think about the artificial intelligence. We published a paper on the effect of fog weather in North India on the data transmission in pacemaker patients on a cloud platform. And I'm happy to share that that's the most cited paper in cloud-based computer technology in the engineering side of the people. So it's time that we medicos should hand in hand with the engineers and develop certain things which can benefit ultimately to the patient.
That's very interesting, Dr. Arya. That means the entire population which has cold climates is at risk of non-transmission of data from devices.
No, they have developed an algorithm by which they can, if that algorithm is used, the transmission of data from the patients with pacemaker becomes faster and quicker as compared to the routine algorithms used.
That's very interesting. So anyway, I've also, like from all the lectures, I've also gained some fresh knowledge, and I thank all the panelists for their active involvement, all the speakers for the wonderful lectures, and of course, finally, Dr. Murli for his, for allowing us to be party to all this program. Thank you. Thank you very much. I think we'll close the session.
Thank you very much.
Thank you, sir. Thank you, sir.
Thank you so much for joining us.